Hello everyone, welcome to Hot Seat. I'm Omid Moghaddas from Tehran, and once again, I'm so grateful and happy to be your host in this next 1 to 1.5 hour. Today, another special guest and a dear friend, a super talented surgeon, now from Canada, is here with us, Dr. Sherif Said. I'm so happy to have you, Sherif. Hello.
Thank you, Omid. How are you?
Good, thanks so much. Today, it will be a very hot webinar in the hot seat because we're going to talk about minimally invasive strategies for management of deficient sites in the aesthetic zone. I think it's one of the most demanded topics in implant dentistry and one of the things that usually all the dentists, all the implantologists are looking for in different seminars, in different congresses, workshops. And I think usually people want to learn from the most skillful people. And now I'm very happy to bring one of those people for all of you in the hot seat today, Dr. Sherif Said.
Thank
So
you.
as a tradition, I will have a brief CV for him to make it as an official introduction, and then we will go to the presentation, and at the end, we will have a discussion on the topic. Dr. Sherif Said received his bachelor's degree in dental surgery and AEGD training from MSA University in Cairo, Egypt, and subsequently accepted a faculty position in the Department of Oral Maxillofacial Surgery following his graduation. Alongside his academic affiliation, he also maintained a full-time position as operator and junior associate in the periodontal prosthesis clinic with his father, Dr. Sherif Said, for 3 years. In 2013, he completed his periodontics fellowship program at Case Western Reserve University, following which he started his postdoctoral training, pursuing both as a KEGS and MSD in periodontology at Boston University, with a special focus on growth factors and pre-implant tissue development. He is both Diplomate of the American Board of Periodontology and Fellow of the Royal College of Dentists in Canada. To maintain his teaching and research interests, he currently maintains a clinical assistant professor position in the postdoctoral periodontology department in Boston University, as well as private practice in Toronto, Canada, and Egypt. Dr. Said lectures internationally and has published numerous referred articles and book chapters on the topic of anterior implant aesthetics, with a strong focus on minimally invasive and cosmetic regenerative procedures. It's again my honor, my privilege to welcome you on Hot Seat, Sherif, and really look forward to your amazing presentation.
Thank you, Omid. Thank you so much for the introduction. I hope everyone's staying safe. I mean, you've done an incredible job about the introduction, so I'm just going to get straight to the point. Okay, good afternoon, good evening, good morning to everyone watching. Thank you, Omid, for this very kind and gracious invitation. It's really a pleasure and honor to be with you today. I'm going to go straight to our presentation. I'll start off with a case just to give you an idea of what we'll be talking about and the scope of what we're going to be discussing today. So our topic for today is going to be minimally invasive strategies for management of deficient sites in the aesthetic zone. But what I'd like to start off with is a case that shows you severe complications that can occur in the aesthetic zone, partly as a result of grafting procedures, suboptimal implant placement, so on. So this patient I presented about 4 years ago now, thinking this was a good case that I liked. But looking at it, this is how the patient initially presented to us. You could see 2 implants that are placed with significant compromise, both in the aesthetics, in the ridge volume, between the vertical and horizontal ridge dimensions, in addition to severe bone loss on the central implant. So we discussed with this patient different treatment options, and we agreed to go for a compromise approach where we would be taking out the central implant and assessing the lateral implants, so the left lateral incisor implant, to see what can possibly be done. You could appreciate from this picture the amount of scar tissue, the high frenum pull, and all the sequelae that happened as a result of the previous surgery. So we go on to the exposure of these areas, and you could clearly see the amount of vertical and horizontal deficiencies and the involvement of the nasopalatine canal. Again, we proceeded with the plan to augment the site vertically and horizontally by using a non-resorbable membrane. This is a DPTFE membrane tacked on the palatal surface with 2 screws or 2 tacks. We used a combination of autologous bone and allogenic particulate bone, and the site was augmented and secured. Looking at it in 6 months post-operatively, you could see the ridge volume has significantly improved, at least on the radiographs. But what we're having now as a problem is actually the soft tissue. The amount of coronal advancement that was needed to augment and obtain primary closure over the site eventually compromises the soft tissue, and then that needs to be addressed prior to proceeding with any implant placement. So we go ahead and we obtain a large free gingival graft from the palate, sutured in place, and then we proceed after 18 weeks of healing for the bone graft, or for the implant placement and the bone graft re-entry procedure. You see the membranes being removed. You have obtained a good amount of volume. This was the previously placed implant. You see it's completely submerged underneath the newly formed tissue. And we proceed with the implant placement as follows, in combination with a minor bone graft and a soft tissue graft to further augment the volume of the tissue. And this is how we have reached 4 months post-implant insertion. You could appreciate the amount of improvement we've had, but we're still deficient in the sites of the papillae, and we're still deficient in terms of the soft tissue architecture. So we give it one last augmentation before we go ahead. And this is at the second stage uncovering once the implants have been integrated. And you can see we placed healing abutments. This is according to Salama and Garber in 95. This is a very simple procedure where we use the healing abutment as tents for the tissue. So we place shorter healing abutments that will later be exposed, and we use those healing abutments to tent the soft tissue in combination with another soft tissue graft. So bear in mind, those are extensive surgeries and a lot of surgeries thus far. And eventually, after this long road, we were able to take the patient from here to here. Now, this is far from an ideal result. We had to alter the tooth shape. We still have to redevelop the tissue. You see some compromise in the papillary area. And we have failed to get a good color match and blending of the tissue. These are all downsides of the coronal advancements that we had to do and all the surgical procedures. So these are not, I wouldn't consider this as a complete success in terms of aesthetics. Maybe in terms of function, we were able to restore this, maybe in terms of improvement, definitely, but not in terms of aesthetic success. Now, the question is, what is aesthetic success? And I think really when you look at a patient or when you look at any situation, we're trying to establish harmony. We're trying to establish harmony between the lips and the gums, so the transition line between both. And we're trying to also establish harmony between the gums and the teeth and or the implants that we're going to be using. The problem is with ridge augmentation procedures, and any procedure, if you will, is that regardless of the technique we use, we will end up with soft tissue distortion that needs to be addressed sooner or later, whether with apical positioning of that tissue to restore the mucogingival junction back to its original position, or with soft tissue grafting that may be needed in severe cases. So those are situations where we have to keep in mind that augmentation, or the fact that we are able to regrow bone, does not necessarily mean an improved aesthetic outcome. There's a functional aspect and there's a soft tissue aspect, which is really the soft tissue preservation. So what we're trying to compromise or reach a balance in between is having enough bone, obtaining that functional long-term stability for implants, but at the same time maintaining and preserving the architecture as much as we can to finalize with a good aesthetic harmony of the case. Which brings me to the topic of today, which is minimally invasive approaches for management of deficient sites in the aesthetic zone. Again, Omid, thank you so much for your I'm very grateful for this invitation and for your introduction. It was very well, nicely put it. Just a small brief about myself. I originally grew up in Cairo, Egypt, moved and lived in Canada for a while, and then returned back to Egypt for my dental school. So over the past 10 years now, I've lived in a couple of different cities. Cleveland was where I did my PERU fellowship, and then Boston, where I graduated from BU for my PERU program, as well as my father about 20 years before. It's where I met my girlfriend, and then we decided that we're going to be moving to Canada. So we went back there. I started practicing a couple of years ago. And if it wasn't for the one on the very right here, Andrea Jelinas, I wouldn't have stayed in Canada. I work with her. She's a fantastic clinician and excellent person. And so far it's been a great ride. So I want to thank everyone on this picture and everyone else along the way, but it's been quite a journey. Now, the outline for today is quite simple. We're going to go over some regeneration fundamentals, evolution in how we've evolved in our surgical approaches and surgical thinking, if you will. And then we'll go over some management of aesthetic cases and some final concluding remarks. Now, again, as we mentioned, in aesthetic implant therapy, we need to find a balance. The balance is between augmentation of volume, which is to give us function and stability, and preservation of architecture. And again, I'm going to repeat those for a while, but this is really the main theme of our presentation. Now, when we look at bone, bone is really the building block for any implant therapy, whether anterior or posterior. This is where we get our support from. And when we look at the literature, usually we have different ranges between 2 to 4 millimeters. 4 millimeters is when we're doing a lot of grafting. 2 millimeters for buccal bone thickness is usually the minimum that we'd like to see around an implant. And this is just to give us some long-term stability of that bone and compensate for any facial bone remodeling around us. But the problem is we're trying to apply rules to different clinical situation. I mean, Omid, between you and I, if you look at our cases, you're probably going to find very different types of defects that we're dealing with, right? So every clinical situation is different, but we can roughly classify them, whether according to severity, according to their orientation, whether they're in the bone housing, so intra-bony or extra-bony, meaning that our graft is going to be mainly outside of the alveolar envelope, or mild, moderate, single, multiple teeth, or full arch cases. If you look at them, this is how I just like to look at them for the purpose of our presentation. We could have some dehiscence defects, could be mild, as you see in the bottom picture, or a little bit more severe, as you see in the top picture. And then you have horizontal defects, which is again going to be a main focus on our presentation. We're not going to be looking so much at vertical, but for horizontal approaches, this is really where we get some differences. You could see comparing the lower ridge versus the upper one, you can see there's a significant concavity on the lower one. This concavity gives you the ridge, the stability for the bone graft, the containment for that bone graft. It also provides you with a lot of cells from the surrounding sites. So to regenerate that lower defect, it's a lot more predictable and requires a lot less materials and space maintenance that's coming from the graft and membranes as opposed to the upper one. The same applies for the vertical deficiency. So now we're not looking at them in terms of just orientation, whether it's horizontal or vertical. To me, it doesn't make that much of a difference. It makes a difference whether the defect is within a contained portion of the envelope or it's outside, meaning that our grafts have to have innate or inherent space maintaining properties, or our membranes have to be more rigid to maintain the space in these areas. So all the space and things, we'll talk about the foundations and the biology in a second. But if all the defects are not treated the same, if they're all not created equal, should they all be treated the same? That is my question, my first question. And if you look at the literature, these are reviews comparing different techniques, and you can see, regardless of the technique you're using, whether it's blocks or GBRs or distraction, you're getting usually a range of 2 to 6 millimeters, depending on the technique, with an average of 4 to 4.5 millimeters of bone, which is usually sufficient for any implant placement. And they've noticed that also the implant survival is quite high, 96%, regardless of the technique employed. Now, if you look at the vertical augmentations, you could see that surprisingly, you would think that you'd have a less of a result, but surprisingly, your range is about the same, your average bone gain is about the same, and so is the implant survival. The only difference is the complication rates go up to 50% because it is a technique-sensitive process, and you are demanding the body to do a little bit more. Vertical defects are a lot less forgiving than horizontal defects, whether for implant placement, whether for any ridge augmentation procedure. So now what we have to do is match the technique with the defect. We have to find an appropriate, technique. Is the sound too high?
Yeah, it's
We have to find an appropriate, a little bit. Sorry about that, forgot to mute them. It's flowing better, huh?
Yeah, it's really good.
Yeah. All right, this slide is causing us problems. All right, so now our trick is to match the technique with the defect. We have a variety of materials, we have a variety of techniques, and we can do basically endless possibilities. The question is, how do we make that selection based on our knowledge of the biology? When can I go for less aggressive approaches? And when can I go for, or when do I need more rigid space maintainers? When do I need more complex procedures to rebuild the site? Regardless of the technique we use, we're always having a downside with these ridge augmentation procedures, and their complications are relatively high. You get significant morbidity if you're going for the donor site for autologous bone, and you're also getting a lot of tissue distortion with these because you have to cut into the muscle, you have to release the muscle, release the periosteum, and obtain primary closure over a larger augmented site. So these are downsides that come in with ridge augmentation procedures, regardless really of the technique that's employed. So in order to make that discernment or to make that decision of what to use and when to use it, we have to go back to the fundamentals. We have to understand how regeneration and tissue engineering occurs. If you look at tissue engineering, you can see that we need three main components. We need a scaffold, we need cells, we need growth factors to orchestrate all the processes. If you look at regeneration, you need a couple of more ingredients. You need wound stability, you need space maintenance, so that clot, that regenerated site that you want, or the site you want to regenerate, needs to be maintained. Otherwise, the tissue will collapse over it and you will not have anything. And you also need the soft tissue seal. So whether it's primary closure or maybe sometimes you could use a prosthetic component. We'll talk about that later. And all of this is just to increase the angiogenesis, to increase the blood supply to the site and the cellular activity of that site. Okay? So when we go ahead and compare again those two defects, you could see that our main determining factor in deciding to augment the site is, or how we're going to augment the site, is the defect morphology or the defect configuration. One defect on the left is going to give me more space maintenance and more cells. That means I do not have to go through larger augmentations or more invasive or rigid barriers to control that, versus the one on the right side where I don't have any space maintenance, and that means I need something that will help me maintain the space by utilizing a rigid barrier like a tie mesh or a PTFE, titanium reinforced membrane, or using a block graft, for instance. So this is really where we start to deviate. And depending on what we have, we can decide on which technique to use and combine them with the appropriate materials. So if I have minor defects or more manageable sites, I can go for less invasive approaches versus when I have more severe or involved areas. And at the end, we have to go back to the principles, which is maintaining the wound stability. So whether we're using membranes or bone grafts, we have to have them stable. Everything has to be closed and stable. You cannot afford any micromotion during these sites. And this is to allow the blood vessels to go in and revascularize the site or proliferate adequately to get more blood supply to the ear. And if you look at what we know around teeth, or sorry, what we know around implants, it came from our knowledge from guided tissue regeneration, which is growing bone and periodontal ligament around teeth. We used to open a flap, add a bone graft, and add a membrane on top to regenerate the bone. Now, what they've noticed was, instead of looking at the type of bone that we were adding and the type of membranes, because they went through tons of literature and tons of studies just to find out the magic bone or the magic membrane to use. It wasn't really about the type of bone that you're using. It's not a brand related thing. It's not a material related thing. It's mainly related to the soft tissue management and the approach they use. So instead of opening larger flaps, as you look in this literature, what the progression was very simple. They slowly kept on opening less, their flaps became smaller, and they tried to keep as much tissue interproximally in between those teeth to maintain primary closure. So they wanted the seal and they wanted the stability. And by opening less, not only does it make better for your patient, but you also have a very stable clot afterwards, which they found to improve their results about twofold. So instead of getting an average of 2.5 millimeters of clinical attachment levels around teeth with the conventional approaches, they were able to go up to 4.2 on average. And this is now how our procedures look. You can see these are two lower central incisors. So this is a very tight space. We open a small exploratory flap. It's a minimally invasive surgical technique. You degranulate the site with special instruments. You could condition the roots. You could use growth factors, all through this very tiny space. And then we pack the bone, but instead of just throwing in tons of bone, we're just rebuilding the site, especially where we really most need it. But because this flap is so small, you can't add the amount of membranes we use. You can't go ahead and stabilize them. You relied on your incision design and your lack of invasiveness or lack of reflection to actually stabilize your entire graft. So you're getting the wound stability from your flap design. Now, the question is, can we apply the same concept to implant dentistry? Can we go ahead and use smaller flaps and limit our approaches in implant dentistry? And this is a case just to show you, it's a case that we did long ago. It was part of a case series. And this is a case to show you what the possibilities can be. This is a young gentleman that presented with two congenitally missing laterals, very similar defects on either side. And you can see they're quite on moderate to the severe side. They're not really mild, but they are quite, they are actually conducive to minor augmentations because they have a concavity in between. You have two bone eminences on the canine and the central that allow you to bridge the gap easily. So we decided to do a split mouth approach where we do a minor tunnel procedure or a pouch, since we're going from the crest, with a demineralized bone sponge, which is purely cancellous bone on the right side. And the procedure looks simply like this. It's a very minor tunnel done with a periosteal elevator. We do not extend the tunnel too much because you want that lack of extension to stabilize your graft. We use some piezo ultrasonics to induce activity into the site, and this is how the sponge is presented. It's a compressed sponge that we can use, and once we hydrate it, you could see how it compresses as it enters the tissue. Do you see that? Omid, you see it clear on your end, right? Yeah, so it compresses as we go in, gives us the advantage of actually getting primary closure without having to release the tissue, without having to cut the periosteum. So you leave the periosteum intact, you leave the flap intact, patients in a lot less discomfort, and you get a very, very fast procedure with a lot less swelling. Whereas if you go for the left side, we don't typically do, and I don't typically do chin grafts. I'm not a big fan of them, but as we did those, you could see that we go ahead. We wanted to compare it with something that's a gold standard, something that's known to work, because Ramus was not that ideal for us. So we went ahead, harvested the chin block, position it in the site, fixation, additional bone graft, and closure. So to compare them, one procedure took about 10-15 minutes, including with the bone grafting, without any periosteal release. The right side took a little bit more with the chin graft. And if you look at the healing of these areas, because we did not release and coronally advance the tissue, even though we have more bone on the patient's left side, so your right of the screen, you still have a good augmentation on both sides, but you also have a better soft tissue contour on the patient's right side, so the side where we did the sponge, because there was no release in that area. And this is the re-entry at 8 months, so let's go over it in details. You can see the bone volume is not enormous. We did not get an incredible amount of bone, but we got enough for us to be able to place an implant, especially in this narrow site. Now, to give us a little boost, we use some additional technology that we have today. We use some densifying burrs or Densa Versa drills to expand the ridge if the ridge is too narrow. But this was just simply to preserve the bone that was present after we trephine. Took a trephine, you could see the bone vitality is actually quite nice, and I've been seeing those on most of the specimens. And the implant placement was performed. The site with the chin graft, honestly, no complications. But then again, the patient went through a very different surgery. And if you notice at the end, to be a little critical, you could see some recession, a little bit more recession than you would like to see on the patient's left side, so the left central, as a result of this multiple augmentation procedure. So, which road should we select then? If both techniques can reach us or lead us to the same path, which road should we select? And I wish I had the answer for you, but our outcomes are not only dictated by what we do. We have patient-related factors and we have site-related factors that are beyond our control. But the more we can modify and adjust in our technique-related factors, I think the more we can make out of the situations we have. And in order to do that, we really have to understand not only how we manipulate the bone. Notice how I'm not talking about how we're doing the bone graft techniques, because I'm sure there are tons of people that could do it better, but it's really how we close over that bone graft, because a bone graft is useless unless you have the appropriate soft tissue closure and the manipulation. So our focus now is going to shift to the soft tissue. And again, the same as we did from around for the bone, for guided tissue or guided bone regeneration, what we learned around implants for soft tissue, we learned from teeth, from covering exposed root surfaces. And if you look at this, we've changed in a variety of things, but mainly it's in those 4 things. We've altered our incision designs. We've learned how to reduce the tension and the trauma to our flaps, and that gives us better wound stability, and you could see that the healing becomes very different for the patient. That means that you've set up the body, even though your patient may have some setbacks, you're setting up yourself for a better situation or success. And if you look at the evolution, it was quite interesting actually. We started off with something called free gingival grafts, where you get an exposed area from the roof of the mouth. So you get a palatal tissue, superficial layers, including epithelium and superficial connective tissue. You create a periosteal bed around the teeth that were to be covered. You'd secure the graft and you'd leave it exposed, because you would discard the flap that was there. And this seemed to heal well. It did not give us predictable root coverage, and simply because the graft wasn't always supplied with enough blood. It didn't have enough blood supply. So then they came on and they decided to do connective tissue grafts, which is basically more or less the same concept, but we just take a different layer of the palate. So we take more of the subepithelial connective tissue, and instead of discarding away that flap, we use that flap to revascularize the graft. The flap now gives us more blood supply, and that seemed to be an excellent solution and was a gold standard for many years. But now as we go into the aesthetic zone, we use a lot more tunneling procedures. And the beauty of tunnels is that we don't reflect the flap at all. So you maintain all the blood supply from the palatal aspects and from the surrounding tissue, which gives us in turn a very stable site. You could see in the pictures second to the last, you could see the graft is there, but it's not sutured, but it's very well stabilized. So all you need is a couple of sutures stabilize. So we start off small, and then we go a little bit bigger. We approach more severe sites. So sites with high high recession or severe recession defects with severe root eminence. And you can still go ahead and do these with tunneled approaches. So our technique, by developing our technique, we were able to approach more severe cases in a more predictable fashion, but also in a less invasive fashion and in a way that's more tailored towards aesthetical outcomes. So now tunneling is a technique that I think is invaluable for everyone at this point. We use them we could add vertical incisions, and that's a vestibular tunnel. We could go from the crest, or you could go from the sulcus. They're all the same, based on the same concept. So it doesn't really matter if you go from the top or the bottom or the side. It's all the same philosophy. It's the philosophy of not disrupting anything. And the same with bone tunneling. We try to apply the same for bone grafting. So you could see now we're not only doing these minor accesses, it's like a laparoscopic procedure or minimally invasive medicine. It doesn't matter where you access. The fact is you're doing a small access in lieu of opening a flap and distorting the tissue, because once you open, you will always lose and you have to correct it. So this is our advantage, is that if you don't open, you don't have to correct it. You can't always do everything flapless, but you can sometimes avoid these larger surgeries. And then that's when bone tunneling started, where they needed to do ridge augmentation procedures for dentures. Then now we're doing multiple or different procedures. You have the SMART technique by Dr. Ernesto Lee. These are all developments of these tunneling approaches or tunneling philosophy. So what we've been doing is trying to adapt what we learned around teeth. And now let's take a look at implants. Now, to start off, before talking about cases, the first question we'd like to ask is, are there situations that are more conducive to predictable aesthetics or predictable implant failure? Yes. Do I see a lot of them? No. Do you see a lot of them, Omid? No, they're not the common ones that you would see. I would love that all my patients would come in with tissue volume that I have to remove. Actually, it's too much. And you see, even the implant placement, you have to place it a lot deeper and remove bone to be able to get that emergence. This is a case set up for success. I mean, I have to remove bone to seat my impression components and to seat my restorative components. Yes, you can get an easy result. You can get a nice result here. But is this always what you're seeing? No, because that's what I'm seeing on a regular basis, where you have these very severe atrophied sites. In the anterior zone, you're dealing with a complex anatomy, and I wish I could go over it, but for the purpose of the presentation, I'd like to focus on the buccolingual dimension and the sagittal root positions, because that's what really affect us in these horizontal deficiencies. The first thing is that buccal plate is less than 1 millimeter in 90% of the cases. So it's really devoid of blood supply. It's related to the periodontal ligament of the tooth. So once you take out a tooth, you're going to get buccal plate remodeling, if not complete resorption. So that's our first challenge. Second challenge, if you're doing immediate implants, which is quite common in the anterior zone, your root alignment may not necessarily coincide with where you want your implant. So that's another thing that we have to overcome. Ideally, we'd like our implants, just to establish that, a little bit more towards the palatal of the incisal edge coming out for a screw retained restoration, but also surgically, it gives us room to graft around this area, the gap between the bones. So we're using smaller diameter implants now. We're moving them more palatal, and we're giving ourselves more room to graft that gap to compensate for the resorption. I have to say it doesn't always affect it. It doesn't always prevent the resorption, but it can substantially decrease it. And if we need to, we could always graft outside of that housing. But they can also see that as the implants are more buccally tilted or buccally positioned, if you look at the histology pictures, you'll see that the level of bone on the facial aspect recedes a lot more. So we're trying to stay away from that thin buccal plate. That's excellent. But then we look at this classification by Joseph Kahn, which really tells you that not all teeth are positioned in the same area in the alveolar arch. You have teeth that are positioned more facial, class 2 and 3, where they're positioned either towards the middle or towards the palatal, and class 4 sites, which is really our topic of discussion, where the tooth encompasses the entire buccal and palatal lingual cortices, and you have no apical bone to support the implant. So class 1 sites become a piece of cake, even class 2. You can recreate an osteotomy, use a round burr, You recreate an osteotomy palatal to the actual root, and you have a lot of bone to engage the implant, and that usually is your best case scenario. In cases that are slightly suboptimal, you could use different techniques, or if you need to augment, you could still do the same thing in a flapless approach, or maybe with a small tunneling procedure. So if we take a look at this case, we have a failing left central incisor adjacent to the lateral implant with already a compromised aesthetics in terms of papillary tissue and papillary volume. So we go ahead, we sound the bone, we check how the bone quality is. But this would be a typical management of a class 1 site. This is, or a socket that is not completely compromised. Because these situations, we're able to actually not only preserve what we have, but we can further boost, we can augment. So I wouldn't stop at just leaving it as it is, because nature is going to work against us. We need to augment a little bit more. So we check the extraction, atraumatic extraction, no trauma to the tissue. And to be as precise as possible, I like in these cases to go for guided. I know guided has different opinions, different drawbacks, but in these cases, they just make the procedure a lot more seamless for the patient, and they prepare us for unanticipated complications, which I'll go with you over in a bit. So we know in this case, we have a small fenestration. I'll show you how we deal with this in the later procedures, but we're mainly now looking at, after placing the implant, how do I further develop that soft tissue? I'm not going to reflect a flap because this is a tricky clinical situation. You already have an implant next to you and your papillary status is not ideal. So we graft, we introduce our tissue graft underneath the buccal and slowly underneath the papilla, and we're able to achieve a relatively decent result considering the circumstances. Considering that these are two adjacent implants with previously compromised aesthetics, I think patient was happy, we were happy for him, right? But it's not always the case. The problems come as we go towards the class 3 and class 4 sites, where the apical bone or the alveolar housing is not really in line with where you want the implant. And this is where you start seeing minor dehiscences. So the one on the very far left, although looks minor, after a few years, it will start having problems. The ones on the right have to be addressed at the same time, otherwise you will have an earlier problem. And I would like to say that these problems don't happen to me, and I would like not to show this video, but I'm sure whether a lot of clinicians, whether they've seen it or not, a lot of people are going to experience something like that, where the implant the bone on the crest is thick, the apical topography is deficient, and the bone, especially if it's grafted, the bone will tend to be softer towards the graft area and the implant will kick out towards the buccal. Now, this is where guided surgery becomes an advantage because it helps you predict and also overcome that. Not always, but most of the time with adequate experience. So with these situations, we can get a variety of problems. We can get mild dehiscences or fenestrations that are still manageable. We can get more complex cases where you start hitting the borderline, and then you have limitations where the implant is in the way, you cannot augment around it. And at that point, this is where implant removal becomes the solution. So now we're going to shift gears to preservation. And to illustrate the power of preservation, this case is really what depicts the entire preservation theme. If you look at this patient, she presented with a failing left central incisor, resorption in the area, and it's not the ideal scenario. So her teeth are not perfectly aligned. It's not the perfect case, but she does have very nice soft tissues. She does have a nice scallop, and it's going to be very hard to replicate this relation between the left central and the lateral if we start playing around with the tissue, because the rechanges, the remodeling and the changes that are going to happen are not going to be predictable and are hard to reproduce. So our best option here is to preserve what we have and try to build based on that. So if you take a look here, this is, to me, is the epitome of preservation, is socket shield or PET procedures, where we leave the buccal shield of the root to preserve the buccal plate, to preserve the blood supply to the buccal plate, and to trick the body to thinking that the tooth is still there and not having to undergo extensive remodeling. Then again, we preserve the bone by using osseodensification to maximize the amount of bone we have available to place our implant. So instead of cutting away a bone, we're trying to densify it and preserve it. And then now, once we've placed our implant, looking at the CT scans and looking surgically, we know we're going to anticipate a small fenestration defect. But you can see the implant's completely encompassed in bone on the left picture. So we could easily just do a small incision right where the defect is going to be, about 4 millimeters away. And we introduce a collagen membrane that surrounds the entire site. And we add a little bit of bone graft. That becomes a seamless procedure, and we can continue on to provisionalizing the case. Now, a small point about this procedure is that the provisionals are of key importance. Provisional can make or break this shield, literally, where if the contours or subgingival contours of that provisional have to be concave to avoid any pressure or excessive thinning of the tissue around the shield, sometimes even complete dislodgement if the crown is over contoured. So that's a very important point of these socket shield procedures, is the restorative aspect. Looking at it in 2 years, and we just did the 4 years, I mean, it looks relatively the same. We were able to maintain everything because we didn't distort anything, okay? So now let's take a look at how guided surgery can help us in addressing and minimizing the deficiencies that we have in more involved cases. Anna came in, she has a very high lip line, complete decay of the coronal tooth structure of the centrals, and you could see root canals, posts. I mean, the teeth are condemned, they are hopeless, with periapical radiolucencies and definitely a deficient apical topography. So we take a look at those, and we follow the same theme or same train of thought. We take out the teeth atraumatically, try to preserve the papillae, try to preserve the soft tissue, no flaps. We graft the site with a dual zone concept. So we're using the soft tissue, we're using the bone to support the soft tissue by adding the bone up to the level of the soft tissue. And we're, instead of utilizing sutures, we're using some ovate pontics to seal the sites. This comes back to classic periopros literature. If you take a look at 4 months, we were able to relatively preserve that scallop of the tissue. Now, this is where guided surgery comes in, because with this guided surgery, even though we have apical topography, and looking at this case now, when I look at extraction sockets now, before I take out the teeth, I plan a vestibular augmentation for that apical area before I place the implant. So at the time of extraction, you not only extract the tooth, you socket graft the tooth, but I also do an additional graft in the apical so that when you come to place the implant, you don't have to worry about it. That was something that we used to overlook, where you just take out the tooth and graft the socket and deal with the rest later. Now it's just become a package where we graft everything the same time, whatever it needs to develop the site to receive the implant. So if you take a look at the CT scan rendering, you could see that we're going to anticipate a dehiscence of that area because we're deficient in the apical topography. And this is, I really think, where guided surgery, navigated or robotic surgery, whatever have you, really helps you, is that it gives you an idea of the plan and you're able to anticipate for any problems, but also control them. It's all based on the plan and it doesn't deviate. So we go ahead with a flapless approach, implant placement, very straightforward. Implants are placed, very simple. We adjust the depth based on 2-3 millimeters from the free gingival margin, and we're able to pick up these abutments now and transition the patient into an immediately loaded provisional. Now, as pros do their work, then you can go ahead and do your augmentation. So you ask her to smile as high as she can. You isolate where her line is. You don't want a scar right around where she's smiling. And we open exactly where we anticipate our dehiscence to be. And if you look at the CT scan and you compare it to this, they're pretty much the same. Even with the discrepancies of guided surgery, you're still pretty much along the same line. So now we do the same thing. We reflect a full thickness tunnel all around. Again, make sure the tunnel's not too wide. Otherwise, you'll have to pack a lot more bone than what you need to. And you'll be reflecting you'll be stripping the periosteum a lot more off of the implant and the surrounding bone than you really need to. So just a small tunnel reflection. 15 by a small membrane, a collagen membrane, cross-linked would be preferable just to stay in a little longer, and some allograft material to help rebuild that site. As you can see, you see the last suture is right underneath her lip here. Is that little blue dot underneath the lip. And this is how the patient leaves. She comes back after the implants have integrated, and we take a look at the aesthetics now. We need to make some adjustments. Now, it doesn't make sense to me to put the patient through all this minimally invasive flapless procedures, and then we realize that we need to do some crown lengthening in the posteriors. So I'm going to reflect a flap and do these crown lengthenings. I forgot to mention that those two laterals that you see are actually canines. She has congenitally missing laterals with transposed canines. So we do our mock-up, and we go with a very minimal crown lengthening procedure, not just a gingivectomy. We're doing the full osseous and osteoplasty through this sulcus. So it's a flapless crown lengthening procedure, and you can see it's quite minimal on the patient, minimal bleeding, and the best thing is we don't have to distort the soft tissue that we've worked so hard to maintain. So you take a look at those, and this is how she looks right after the procedure, right? So far she's happy. She didn't have to go through hell. And that way, the prosthodontist has to work a lot less. We have to work a lot less. The patient's a lot happier, and the result, I honestly think, was quite decent. She was quite pleased with the result, especially with that area. You can see the implants are augmented. The bone is a little bit higher up. This is one of our earlier ones. Bone levels were maintained. And this is the before and after procedure with two canines that are substituted to look like laterals and transitioning her smile into a more harmonious smile. Now, not all cases go like this, and guided surgeries has its downfalls. Guided surgeries is not bulletproof. An understanding of the bone, understanding of grafted bone behavior, understanding of the anatomy, and understanding of how and when to drill guided versus going manual sometimes is critical. So this is a case we had on with one of the residents actually at the school. I supervised that, Dr. Harkan, and you could see that tooth number 8 was completely fractured, severe palatal and buccal infections, compromising the bone, and extrusion. Now, this is a sensitive case. We have high lip line, we have a high scallop, and it's really a front tooth on this very pretty girl. So we can't just take chances with this. So we go ahead, take out the tooth, again, flapless, but as a result of the compromise of the buccal plate, we decided to go with a collagen membrane, some bone graft, and a pedicle graft. So we're trying to augment the bone, we're trying to augment the soft tissues, and we're doing all of this flapless. Now, I don't think this is minimally invasive because it involves a lot of procedures. This is still a pedicle graft. A pedicle graft is not really the least invasive procedure we have. Yet again, it was all done through a flapless approach. I don't think flapless approaches are necessarily minimally invasive. It all depends on what we're doing. So this is how the area was sutured. And as far as soft tissue augmentation goes, I prefer to augment the tissue at any of those 3 times. And those are really the main 3 times that you can augment the tissue unless you wait till crown delivery. It's at the time of tooth extraction, at the time of implant placement, and at second stage uncovering procedures. And you can see most of the work that's done is done under tunnels because you're trying to keep that bone by not reflecting the periosteum over it. So you're trying to keep everything in place. And the importance of soft tissue around implants has just been reiterated in literature over and over again, especially the thick tissue anatomy and the thick tissue importance for these sites. So thicker tissue has less crestal bone loss, less marginal tissue recession, and less discoloration or show-through of the restorations, which is critical really when it comes to the aesthetic implant therapy. You can compensate for it restoratively, but with using zirconia abutments, but usually tissue thickness is critical also for bone levels and bone level maintenance. Now, in that previous case, I showed you that we did a bone graft and a soft tissue graft all at once. This is usually a good augmentation, provided that you have bone on the facial. As your bone support on the facial decreases, so in moderate or in severe cases, if you add too many things, you know, when you tell you too many cooks ruin the, ruin the pot, this is adding too many things at the same time, not in the right time. So if you look at severe deficiencies, because we do not have a buccal plate that is holding the form of the ridge, if I add the bone graft and I add the tissue graft on top, my tissue graft is actually going to work against me. It's going to augment the volume of the tissue, but it's going to compromise the amount of space that can be occupied by the bone, which is what we need. So in intact sites, I'm all for doing soft tissue and bone at the same time. In severe sites where we don't have a buccal plate to maintain that bone volume, you can actually end up with a deficient ridge in terms of bone if you combine both at the same time. So we're trying to look for options to overcome this scenario. We know that you could use a collagen membrane to reconstitute that lost buccal plate at the time of extraction, but can we do something simpler, or can we modify our technique slightly to avoid that? So this is a very similar case to the one I showed you, but just to outline the point. If you look at this case, we have complete loss. So the implant, she had a failed implant that occurred about a couple of weeks prior. See, we were left with complete compromise of that socket. And that buccal segment is actually not fully integrated. I had to scoop it out because this bone was all grafted on top of the implant. There was no retention, or there was no consolidation of that bone graft material. So we take a look at this case, and I look at this site and I compare it to a class 1 Joseph Kahn extraction socket. It's basically the same thing. So we go ahead and we take out we do a minimally invasive approach. We degranulate the site. Again, you can see I'm using Densa a lot in these cases, just because if I have a limited availability of bone, I don't want to cut it all away. So we do a small punch, and you can see how thick the tissue is here. She was a good healer. We go ahead with our implant placement, and then we do our augmentation, but we do it in a slightly different way. Instead of adding the bone and the soft tissue all on the buccal surface, we segment the areas. If you look at the right of your screen, you can see we've introduced a membrane, which is in blue, all the way to the level above the platform of the implant. So we're placing the membrane just around, or placing the bone just around the level of the implant. And then that soft tissue graft, which I obtained from the punch, we just open it up, it's like a butterfly, and we use the soft tissue to augment just the crestal portion. That way, the soft tissue graft is not impinging on the bone that we're going to do. So once we secure everything, if you look on the right, you will see that the bone is all around the implant and the soft tissue is just at the crest. It's at the buccal crestal line angle, which is really where you want the tissue, where you want the coverage and thickness to protect your implant. So that was kind of just a small modification of what we do. Again, with the implant placed, you could use a custom abutment or a regular abutment to seal the site, so we're getting closure over that area because we didn't open a lot. And this is how the site was delivered, and this is how the implants look. You can see the tissue was well maintained. You can see her soft tissues were relatively preserved, and very minimal trauma to the patient. But it takes you longer time, and it takes you a lot more patience to do these procedures because you're working through a very tight axis, which is the whole concept of us doing this. We also looked at another thing which was published on in 2017, late 2017, with Dr. Nevins. And this is just to incorporate a growth factor along with the bone graft and utilizing no membrane. So in cases where you had complete buccal plate loss, you would incorporate the bone with the GEM21 surrounded with a small collagen barrier or collagen membrane on the top, on the occlusal surface, to help clear or to help seal that site. And that was it. And I'm doing something about it now around implants. So back to our original case. When we look at this case in 5 months, you can see that the ridge volume was preserved nicely. The bone looks consolidated well. Everything seems in order. So we go ahead and we follow the same protocol with a guided flapless approach. But as you're coming to place the implant, sometimes this bone is not as well integrated. It could be a fault in the procedure itself. It can be a defect in the actual degranulation and grafting of the site or membrane adaptation. So they are technique sensitive. They're not always the best solution, not always the easiest solution. They're also a lot more time consuming. So if you're running late on a patient, that's not the one you want to do. So we go ahead and I take a look. I'm like, okay, I feel that the implant, there's something wrong with the bone. So we go ahead and I explore the area. Even though the implant was at a very high stability, you could see there's quite a significant dehiscence. Now I had to make a decision with the patients. Should we try to graft around it, or should we take it out and just attempt to re-angulate or attempt to remove it and regraft the area? This is a decision we had to make. And I'll show you why I decided to do what I did, but we decided to graft. And I know this seems a little bit more cavalier than normal, but I'll tell you why we made this decision. Now, that soft tissue punch that I take to access the area, I don't throw it away. Again, we use it as a butterfly, and I use it to augment that crestal portion. I don't know if you can see my mouse, Omid, but you could augment this crestal portion of the ridge, secure it in that area, and give some reinforcement and tissue thickness right at that crest of the ridge. And you could see this is how the case was finalized, and this is how the area, oh, sorry, let me go back. And if you look at it from the occlusal aspect, you could see that the entire implant is within the alveolar envelope without, you see that? All of it is within the alveolar envelope. So that gives me predictability in grafting these sites and longevity. Now, the one thing that we did experience with these cases where we're adding a lot of bone through these vestibular tunnels is that some of the bone graft particles can get encapsulated, whether in your incision line or exfoliate slowly through your incision line. That's something you have to be careful. That happened to this patient after 2 years almost of function. It was just merely a removal of the crown, retrieving the crown, cleaning the area, removing any loose particles and replacing it back on. So it's not really a detrimental problem, but it does happen if you're using tunnel access, especially if you're not using a membrane. And then the final case would really, I'd like to show you to tell you that it's not I mean, these are all in progressions. You could easily do minor cases, but as you come to do more severe cases, this technique becomes more and more technique sensitive. So when you look at this case, you have a patient that presented with a heavily restored dentition, especially maxillary arch, severe recurrent decay on all her teeth, and interproximal bone deficiency in the anterior segment you could see with the loss of the papilla. So this is not a good case to go ahead with immediate implants, but let alone, or nonetheless, that was what was done. So teeth were extracted, the implants were placed, and I want you to pay attention to your lower left picture where you have one implant that's completely bodily position palatal and the other implant with the crest, the platform of the implant angled towards the palatal, but the apex of the implant was not fenestrated, but was slightly towards the buccal than I would like. Looking at this, we did the implants, the bone graft, same procedure as we would do, and this is how the initial healing was. So we talked to the patient, and then as we were waiting for her other prosthetic work, we were going to do some fine-tuning of the soft tissue in the meantime. So we followed the same protocol, vestibular incisions, tunnel access. We were trying to augment the papilla and also augment the thickness of the bone. But as you're working, you can see that this implant, so this was done for both sides, the two lateral incisors that had the implants. Both implants had dehiscences. One had, this is the left side, this had a more severe dehiscence with the implant completely outside of the bone, right? Now, you could try it. You're probably not going to have the result that you're looking for. Looking at this, you see that area was, we did the same protocol, piezo for decortication. We even used some tacks through these tunnels to stabilize the membrane and give us some space maintenance and stability. The site was grafted, and we introduced a couple of tissue grafts to augment the volume of the tissue and papilla. So this is a Hail Mary. This is going the whole, trying to rectify a situation that was handled incorrectly in this to start with. And take a look at this. This is the immediate post-operative view of this case. So a little bit of improvement, but 1 week comes, right side heals quite well. Left side, we have a disaster, right? We're probably going to end up with a problem that's worse than where we started. And again, if you look at it, it's all in the picture. You could see the blanching of the interproximal papilla here. You could see the amount of tissue trauma that happened to that site. These sites are probably going to have problems. So it comes back again to tension and trauma. If you compare those two, this is another case just to illustrate this point. These are two lateral sites that have the same exact deficiencies. Both were treated with block grafts. One side, we used microsurgical sutures, so 6 O's and 5 O's for the suturing with a layered approach. The lower side, which is the left side for the patient, you could see thicker sutures, a lot more sutures, and less distribution or less favorable distribution of the sutures. And this is where your flap manipulation and tension and trauma come in. When you look at these cases at the early healing, you could see the one with the microsutures, you could see the advanced healing at 3 days. That area is sealed. You have connection between your wound edges, and you have a very favorable healing situation. As you look at the bottom one, you could see that this area has sloughed. You could see the fibrin deposition as a result of the poor healing and the trauma from the sutures. And in a patient with an unfavorable healing potential, you can actually get an exposure of your graft just simply from that. Simply from having too much trauma around the wound edges, which is already the least vascularized area of the graft or of the flap, and that could expose your graft. So eventually we pulled through, but you could see how sometimes these things can make or break a case. If you're earlier healing, if your surgical technique is not geared towards helping the body heal, it cannot do it on its own. And you could clearly see that in the early wound healing. So then we opened the site, and I'm assuming to see problems on both sides, but surprisingly, both sides were treated the same way. The left side and the right side had the same exact approach. Both had implant dehiscences, both had the same tunnel bone graft, both had the soft tissue graft. You could see one side regenerated completely. So the patient's right, or your screen's left side, you could see that we were able to completely cover the implant, both on the facial and occlusal aspects. If you look at the right of the screen, you can clearly see as well where we were able and why we were able to cover. So on this side, we were able to get cellular activity, cellular migration from one side to the other because the implant's not in the way. On the right side, you could see that our cells stop right as our bone growth stops just as right as the just in the moment where the implant is sticking out. It's interrupting the space. It's interrupting the cellular migration. It is occupying the space for the graft. So you could look at those as half full, half empty type of thing, where you could see the left side worked, right side didn't. There are biological reasons for it. It's not haphazard. The reason is simple. We didn't follow the main principles. We didn't have cells because the implant was in the way. Our soft tissue seal was inadequate. We didn't have the space to regrow the site, and consequently, we compromised the blood supply to the area. So again, if we boil down things to principles, we're able to get an idea on a case-by-case basis of what we can do predictably and what we can't or should not do, even if it works short-term. So we're working on something that's a little bit more of an algorithm type of approach or a classification type of approach, but this is just to simplify it. For sites that are compatible with implant placement, meaning that the implant can be placed within the alveolar envelope, and you don't anticipate any dehiscence or any fenestrations, then you leave it as it is. You augment what needs to be augmented if needed. If you anticipate a dehiscence or a fenestration defect, this may be prudent for you to use two things. Guided surgery helps control the accuracy and helps control the implant positioning as you're going, so you're able to minimize the amount of exposure you get of those threads and optimize the position of the implant. You could also use osseodensification for these areas, because instead of cutting the bone, especially when it's thin, you could use this to densify and expand it slightly, especially at the apical portions, where you can make your graft a little bit more predictable. Having the graft on bone is very different than having it on an avascular implant surface. And in these cases, if they're minor, you could go for vestibular or occlusal approaches, or even if they're moderate and contained, you could still go for vestibular and occlusal approaches. It depends on what you're comfortable with. For sites that are not compatible with implant placements, such as cases that have deficient sockets, but also have compromise of the apical topography. This is where we changed our thought process, where instead of just doing a socket graft now or a socket preservation, we do the vestibular augmentation at the same time. So we do both socket and the apical portion to rebuild the ridge. Because if you're not doing both, you're not fully rebuilding the site. You're just doing a partial graft. That's not enough. You're still going to need to graft later on, or compromise in the implant angulation. If there's a compromise in the socket, and unfortunately, Omid, we didn't have a chance to go over it this time, but if you have a compromise of the socket, you could go for aesthetic ridge augmentation with a membrane or growth factor, and then depending on how the tissue thickness is, connective tissue grafts may be needed. And if you have a combination, this is where we'd really look into open approaches or flapped approaches to get better access and better adaptation of these sites. So this is really the main portion that we've changed in our protocols, where we go ahead and we graft both the apical and socket, the apical part and the socket at the same time, utilizing a tunnel in combination with the grafting procedure. So for our conclusion, limited surgical intervention is possible, provided that we conform to the basic biology. We can employ minimalistic approaches to help better preserve the soft tissue architecture around implants. And we should be very careful in our defect selection, because this could make or break your case. So this is really the dictator for what you can and cannot do in these cases. Thank you for your attention, and thank you for having me. And always a pleasure seeing you, and always and pleasure being on here with you.
Thank you so much, Sherif. I really have to appreciate for your comprehensive and with very new materials in the presentation. And as I said at the beginning, it's one of the most demanded topics that I'm pretty sure most of the implantologists around the world looking for. Me personally have lots of questions and thoughts on this, on all of these procedures, and I really wanted to share it also with the audience. Speaking of dehiscences and fenestrations, you had very beautiful cases and very beautiful managements, especially in the cases that the patient had a large dehiscence, like a type 3 socket, but soft tissue was good, but the bone was gone, like type 2 socket, better say. And you used membrane and connective tissue at the same time. You called it a butterfly. You fixed the connective tissue at the very top and put a membrane around the dehiscence. So yes, this case. So my question is this: is it a predictable approach in all type of scenarios? And I believe that it really needs lots of skills. And as you mentioned, the flap should not be completely detached to make sure that the membrane doesn't move. So first, I want to know, as a guidance to all of the practitioners, is it a technique that we can utilize in all type of defects similar to this one, or there is a specific criteria for that? And the second part of the question for this case is that when we fix connective tissue on that very top level, because we have implant in the back and
Yeah.
there is like bone graft material on top of the implant, and then we have the connective tissue, and the only source for the blood supply for that connective tissue is the flap. So is it the risk in such cases to face the necrosis of that connective tissue, or is there any way that we can enhance or maximize the vitality or remaining of the vitality of that graft?
Good. Excellent question. Thank you. Now, definitely not in every case. These are case selective, and I usually reserve them for patients that really have a high aesthetic demand, or patients that have gone through multiple procedures. But this is not something that you can do with the naked eye. I have to be honest with you. It's like you doing endo without a microscope. It's the same concept. The more magnification you have, the more of the correct instruments you have, yes, you can probably do it, but you need the right armamentarium, and it's a time-consuming procedure. So if I'm running late on a patient, it's not really my go-to. I have to extend these patients for a little bit longer. But they are, and again, not all defects are conducive to this. The Dehiscence defects, I have another portion, so this is mainly towards fenestrations, but I do have another portion on similar concepts for management of the dehiscences. And it all goes back to where we place the membrane, how far do we tunnel, where exactly do we tunnel, but that's a more detailed approach. The thing is, they are demanding, and they are predictable, but the one factor that helps us or doesn't help us is the defect configuration and the position and where I could place my implant.
Mm-hmm.
If my implant, these are, again, this is a case where you could see the implant's completely away from the previous site. So this gives me more room to operate. But through that small punch, I'm able to go in underneath. You need to make sure that you've removed all the periosteum off the bone. So you can't have a split thickness dissection. That means you need to have instruments with different angles. And you need to make sure that you have a membrane that can help you do that. You can't use a flimsy membrane. Otherwise, it will curl underneath. You need a more stiff membrane to introduce it underneath. It does take time. I won't lie to you. And it takes a lot of time, mainly to degranulate the site, make sure you've excluded any soft tissue. Otherwise, you have a problem. So that's for that part. So yes, it can be applied. I wouldn't tell you I do it on everyday basis, but I can tell you that this is something that I've incorporated in my armamentarium to utilize in situations that are needed. Very high lip line patients, patients that have gone through multiple surgeries that I don't want to flap anymore because I don't want to lose any more tissue. Mm-hmm. Now, as far as the tissue graft, and I'm not sure I was clear on that, but I don't actually, I stopped harvesting the tissue. This is the same tissue from the connective tissue punch, the occlusal punch that we did, okay? And that tissue seems to be excellent for two reasons. First, I don't have to go for a donor site. Secondly, I don't have to worry if it works or not, but most of the time, or it never has not worked. The reason being, your graft is right against your healing abutment.
Yeah.
Let me show you another picture. Right between your healing abutment and the flap. So if you actually look at this picture, that space between the flap and the healing abutment, that is where the tissue is. It has enough blood supply, but it's also very, very stable to the extent that most of the time I don't need to suture them. So I've never had a problem with the necrosis. I wouldn't anticipate it, honestly, because it's very well sealed. Now, if the graft is too big and you're pushing it in and it's tending to ooze out, that's where you may have a problem, because once you leave it, it's going to go away. But if your graft is fitting comfortably and is fully covered by tissue and stable, you should not have a problem with that healing.
That was a great point. Yeah. So the preparation is the key, and I really wanted to hear it from your side for the audience that it really needs skills, and it's not something that you can just with not good instruments, with not good vision, with not, you know, you cannot do it like that.
No,
It takes
no.
times, it needs skills, expertise, and definitely the design of the flap is very important. One of the other questions that I have was about those lateral incisor areas that in one area you push the graft into the tunnel, the other one you use the chin block.
Yeah.
One of the concepts that is out there, and I personally heard it from Joseph Shukroun, was that the pressure against the graft material usually cause the resorption.
Yeah.
So I love this approach, and I have it in my practice also, that I don't like to have my flap to be completely mobilized. I want the flap, as you mentioned, in a specific area to be released, and not more than that, to make sure that it contains my graft. So exactly the same thing that happened here. My question is that, is there a risk for pressure from the flap side to the graft material and cause more resorption?
So this is why we went for, we're still going on with it, but the problem is they changed the material we're working with, so stop the study. But you could clearly see it on the left slide. If you look at it, you'll see that the amount of augmentation right at that buccal crestal line angle, so right at the crest, you could see it's compressed in because the tissue is compressing over.
Yeah.
That's the same also with GBR procedures. You'll see the same thing, that line angle, instead of having it like this, it tends to curve in, and this is where you really need the bone. So yes, that does come at an expense. And when I do these flaps, so it's different when I do a regular flap than a tunnel. A tunnel, I like to keep it tight. A regular flap, I open it up. I don't have a problem with doing those. So those are two different things, but these sponges, sorry, repeat the question. You said you have a risk of perforating the flap?
No. The pressure from the flap, I said that pressure from the flap can cause more resorption of the graft material. So the reason I asked this question was to know that what's your idea and thought on going with the Vista approach from the side and not from the crest, and push the graft material like the SMART approach by Ernesto Lee. Put it laterally and push it up to the crest to make sure that your incision line and suturing doesn't cause any pressure to the graft toward the apical.
So I think this is, and I talked to Ernesto Lee about it, this is a drawback of having the tissue in place. What you look, that's an excellent question, because we went a little bit further from this, and instead of trying to close over it, we tried incorporating a tissue graft to substitute. So instead of having the flap completely push, we keep it, yes. So the ridge looks more of a straight line. That's an excellent, we're on the same thought process. Yeah, I think whether you do Vista or the crest, the fact that the tissue is bound from the crestal portion, it's by nature is always going to push you inwards and downwards. So towards the crest and towards the apex. Vista or the other options. And we've seen it time and time again when you do these tunnel procedures, or even when you do a flap that has a lot of, where you could see the tension on it, always, even the block graft, you could see it rounds off at the crestal angle. It's just how the tissue pressure is. Can be an option to relieve it from the Vista. I've tried both, but I found that if I don't open the crest, I have a trouble stabilizing the graft right at the very coronal portion of the ridge. I don't know if you found the same. Have you found the same?
Yeah, that's the problem, because you cannot control, that's the area usually very thinner, and usually the width, especially in the single tooth area, is narrower, so the control is not that easy. You know, in theory, we can say it easily, but when we want to do it, it's not that easy. And about the choice of the graft material, in this case, you mentioned that you used cancellous bone and demineralized one, if I understand right.
Yeah, so it's a they changed the company changed. Now it's available by a company called Surgical Aesthetics, but I don't find it's the same material. Um, it used to be, so it's a demineralized bone, trabecular bone matrix. It's not like the BioOS collagen that has filler content.
Yeah.
So it's an actual piece of bone, trabecular bone, that was demineralized, so it's spongy. It was a very interesting material.
It's fast.
Sorry?
It's fast resorbing, not slow resorbing.
It's fast resorbing, yes, it's fast resorbing. And it takes longer. So that's another, we're looking at different materials for this. This was an ongoing thing, and then we kind of deviated into a different approach. But we're looking at it. It doesn't seem, but the interesting part about this case was not really the material, but the fact that something so simple can work, as opposed to, see, it's just, I mean, even if, and it's not just a one-time thing. We did it on a multiple thing. We actually did it in 2011s and 12. So we were doing this without any membranes, and they seemed to have very nice results. They weren't as consistent until we kind of refined the technique, and then the material disappeared. So this is just, and that's why I don't like to stress on it again a lot as form of the technique or the material, but just as the reason why it worked and how it worked. It worked simply because the defect allowed you to do that. It's a minor concavity in the area, so it allows you, it has more cells and more potential for it to grow. It doesn't, I wouldn't take it to heart on severe ridges or more compromised site. You need an occlusive barrier, you need the fundamentals. But for some sites, it can be a nice alternative, possibly.
Great. And Sherif, my final question, because your cases are, all of them are beautiful, and we can have a chat on them like 24 hours. But my final question for today is regarding those cases that, as you presented in many cases, that have fenestrations in the apical part. And but not in the cases that we predict it happens, and at the same time of implant placement we can do the reconstruction. Imagine the same scenarios, but with a patient with an implant that has been placed like 2-3 years ago, and now in the evaluation you can see the fenestration, you can see the darkness through the tissue, or through the CBCT evaluation you notice that. In such situations, number one, if the tissue is healthy, do you prefer to re-enter the area and do some grafting or etc.? Or if it's healthy and patient have no complaint, do you prefer to leave it there and go with the follow-up of the patient? That's
definitely, if it's not symptomatic, if the patient's okay with it, you don't want to go in there. These cases, I found that it's a little bit more difficult once the implant is outside of the bone to predictably regenerate, because you can never mobilize the flap or the tissue far away enough to incorporate it, and the implant's in the way of augmenting the bone. And those are the cases where I was telling you about, where you tend to see a little bit more exfoliation of the graft, or if not, you will find that the patient always has discomfort over the implant. They can't pinpoint what it is, but it's just the bone over the implant with the thin mucosa there. So if I can afford not to do anything about it, definitely. If I need to do something about it, that becomes a matter of where the implant is positioned and how far it's positioned out. And that's where we have to have the discussion, if it's something that we can do predictably or not.
Yeah, but
in some cases it can. Go ahead, sorry.
My question is that in those cases, because the implant has been exposed for many months or years, and it was in contact with the soft tissue, is it possible to, especially if it's outside the bony housing, is it possible to build up a bone on that implant surface? Will the osseointegration happens, or it's just like barrier between the soft tissue and the implant? And
Yeah, I wouldn't count on the, sorry to interrupt, but I wouldn't count on the osseointegration, definitely.
yeah,
I would not consider that, considering not because of the fact that the implant is contaminated per se, but the fact that the implant has, as you mentioned, some contact with the soft tissue, and the fact that you cannot always easily reflect the soft tissue off of that implant surface, it wouldn't be the best thing. Now, can you get, if there's a small dehiscence or fenestration and you're able to get bone all around it, the question is, does it really matter the amount of osseointegration do you get around this implant? And it may matter in the crestal portion where you're susceptible to bacteria, where that could be a weak spot for your implant. But for the apical portion, does it really
doesn't matter.
affect you? And is it worth doing if the patient doesn't have any symptoms?
And do you consider implantoplasty on that area or no?
This question has been coming back out a lot. So I'm a big proponent of soft tissue in general. If you were to talk soft tissue grafting around the hist implants, I'm a big proponent of it, especially if I know that the implant's a little bit too far facial or I can't regenerate the bone around it. Okay, this is my go-to because that's your next best option. I was exposed. So when I was practicing with another periodontist that loved implantoplasty, and I did a few of them, a couple of them, and then I started liking it a little bit more. But I'm not really going to do much about it. Whether sometimes I do it in the crest where I need to smoothen off just to give some room for my graft. But in that bottom area, I mean, honestly, I haven't thought about it. I haven't thought about even doing it. Can you believe it? Do you do a lot of implantoplasty?
In the cases that the threads, especially in the dehiscence cases, the threads are exposed and I have recessions around the implants. Usually if it's outside the bony housing and if I want to have the implant coverage, I go with the implantoplasty to reduce the contour and maximizing the success, and it worked. But in the case of fenestrations, I didn't have that much cases to do the implantoplasty on that, but I think it's not a bad idea. And that was why I wanted to ask you, because you had beautiful cases. So I just wanted to know.
Never thought of it, actually. I never thought about doing it in the apical portion, but it can be an option, especially since you're not weakening the main portion of the implant. It's, I mean, if it's exposed, it's not supporting the bone, you're not going to be worried about compromising the prosthetics or the implant resistance in that area. Yeah, that's a good point. That's a very good point.
Good.
Try getting the burr in there, though.
Yeah. Sherif, it was a really fun time, great time having you and your amazing presentation. I really love the discussion part. And
thank you.
I have to say just thank you. I don't know how to appreciate you, and hope to have you very soon in Iran also after all these lockdown and such things.
Hopefully.
And stay safe, my friend. It was really good chatting with you.
I can't thank you enough
on the show.
Thank you, my friend. Thank you. It's a pleasure being here, and stay safe. Hopefully everything will be over soon. And to everyone that's watching, everyone stay safe, please. And I wish you all the best. Thank you, Omid.
Thank you so much. Bye-bye.